Let's talk about brain health and brain injury, perspectives from Global Atlantic Fellows for Equity in Brain Health. My name is Gráinne McGettrick, and I'm a current Atlantic Fellow for Equity in Brain Health in the Global Brain Health Institute here in Trinity College, Dublin. And in my day job, I work in the policy and research space for Acquired Brain Injury Ireland, an Irish NGO providing community-based neuro-rehabilitation services for people with ABI. Something remarkable is happening in Dublin this week. The World Congress on Brain Injury is taking place here in the city. Over 1,000 brain injury experts from all over the world will gather in Dublin for the next 4 days to discuss all things brain injury, providing a unique opportunity to share research and best practice, network and learn from each other, and generate new ideas to address the many challenges we face in the brain injury world. I am delighted that we were able to host today's satellite symposium to coincide with the Congress. I am joined in person by our 4 world-leading experts and senior Atlantic Fellows who are here for the Congress. A warm welcome to them, and I will introduce them to you as we move through the agenda. Today's webinar will involve 4 presentations, each 10 minutes long, and then that will be followed by a panel discussion for 25 minutes. This event is a follow-up to a GBHI roundtable event that was held last December. This roundtable brought together 21 experts in GBHI from across the world to discuss and begin to unfold the issues, the challenges and opportunities in connecting brain health and brain injury. The roundtable participants discussed the importance of taking a life course approach and paying attention to prevention, diagnosis, treatment, rehabilitation, care and support needs, including people at risk of neurodegeneration. So if you want to learn more about this discussion, the report is available on the GBHI website. So before I introduce the first speaker, if you have any questions for the speakers as we move through the agenda, please use the chat function and indicate in the chat who you wish to address the question to, so that they can respond. I'm now delighted to introduce you to our first speaker, Dr. Eleonore Bayen. Eleonore is Professor of Medicine at Sorbonne University. She's a Director of Neuro-Rehabilitation based in a large teaching hospital in Paris. And as a physician, she's an expert in the complex care of patients with traumatic brain injury. The title of Eleanor's talk is Prevention of Traumatic Brain Injury, Education and Awareness, and the Role of Brain Health Education.
Thank you very much for the invitation. I'm very happy to be here. And so I will tell you a little bit about prevention of traumatic brain injury and the role of brain health education. So why is this question about TBI of interest for our GBHI community? We all know that TBI is associated with an increased risk of dementia. And so TBI is really something that can be leveraged because it is a modifiable risk factor of dementia. We also know that TBI is associated with health disparities, with inequities. There are different and distinct incidences of TBI among vulnerable groups, also worse access in some people to TBI expert care and worse outcomes. So this, of course, makes this question also really interesting. And finally, as in many countries, sorry. Putting on my video. This is me. We're good? Good. Sorry. And so the third point of interest is that there is in France no national plan, no prevention campaign. And this is also the case in many countries. There are as many stroke as many TBI in France and worldwide. And on the contrary, while there is a lack of clinical guidelines, as I said, no prevention and national plan. And so this is very tremendous opportunities for us fellows to work on this question. Talk about TBI and prevention. There are 3 levels of public health prevention. The first one is about primary prevention. How can we reduce incidence of the main mechanisms of TBI? So, you know, it's about trying to decrease the number of road traffic accidents and falls, which are the 2 main mechanisms, but also, you know, leisure time activities that are dangerous and information about sport concussion, for instance. The second level of prevention is dealing with the fact that when we have primary injuries in the brain, hematoma, etc., we will try to mitigate the severity of the injury. So this is what we call secondary prevention, and there are 2 key time points there. The first time point that matters is what happens during the ICU phase, the intensive care unit. And here, monitoring oxygen, blood pressure, etc., is really of interest and matters a lot for later outcomes. The second time point of interest is rehabilitation, where neurocognitive rehabilitation will really make a difference. The problem is there is not enough care pathways taking care of those patients with TBI, but they really need this expertise from speech therapists, neuropsychology, or people who really will help them, recover and help brain plasticity around cognition. And here, new technologies such as serious game here, for instance, is also helping to reach more people who don't have access to this expert care. And finally, tertiary prevention, it's about, dealing with the disability situation. And I don't have too much time now, but one of the key issues around TBI is litigation. TBI is the only pathology that has this special link with finances that can come from the third party who is responsible for the road traffic accident, for instance. And this can really make a difference in people's life because they get lots of money that can, better their quality of life. So where does brain health fit in all this and in this TBI prevention? So the first key idea is that brain health has a role to play in secondary prevention for adults and children with TBI. And this is what my poster will be about that I'm presenting to the World Congress tomorrow. The idea here is that outcomes in TBI are highly variable. We have lots of difficulties to predict the disability situations of people later in life after their TBI. So what you can see here on the left is two papers that I co-authored, and it shows the variability of trajectory of patients. So on the graph on the left, you can see initial outcomes in the intensive care unit, so a few days after the accident, and then a second point, which is at 1 year later. So green shows that people have favorable outcomes and they stay mainly with favorable outcomes 1 year after. Then in red, you have those for those with unfavorable outcomes. And you can see in the middle, the gray zone, which is very hard to predict. And this is here something important to stress, that we need objective tools in order to avoid self-fulfilling prophecy. And here it's an MRI study where we show that MRI is not enough, does not bring enough information to predict for those people who all are in ICU but are in the gray zone. And we don't know so much which one will get favorable, so in green outcomes or unfavorable outcomes. The second graph is also from my group, and it shows also with the GOES-E, Glasgow Outcome Scale Extended, which is our gold standard scale for TBI. It shows the different trajectories between 4 years post-injury to 8 years post-injury. And you can see here also in blue and red that many outcomes are unpredictable or hard to predict. And here again, it's to show you that many variables are at stake. So that's what we see here in the middle. The idea is that we have acute biomarkers, MRI, blood biomarkers, which are important and will predict brain vulnerability, but also environmental factors and access to expert care pathway. And among those invariable factors, we have the lifestyles which matter, and this is where brain health fits in. So cognitive stimulation, access to physical activity, not having different second brain injuries, healthy diet, healthy sleep, treating epilepsy, hypertension, diabetes, and cognitive stimulation. So brain health is really a new psychoeducation that matters a lot in our follow-up care in TBI. And to finish with, I will just spend a little bit more time about primary prevention in youth. And so this is where my pilot grant that I started 5 years ago entered. So we created mybrainrobbie.org approach, which is an empowering approach and aims at translating the understanding of brain health into action. So we built a narrative that is adapted to children to support them about easy steps to protect their brains throughout their life. And you can see here the different factors, modifiable risk factors. And we do interventions in school setting to explain to them how to do that. So we have a model for that, a pyramidal multi-level training model, where we just first train and empower students, and then those medical students will go into school settings and raise awareness in children. So as you can see on the right, one faculty will train a group of 50 students within a day, will in the end result in reaching over 3,000 children, because the medical students then go in DIAs and do a 2 hours training in 2 weeks in school settings. So we reach around 6,000 people per year, children per year in the Parisian area with this model. So we have different activities, and the last module that we developed this year is about TBI prevention. So the idea here is not only to bring information to the children, but to have them think about their lifestyles and their behavioral changes. So we work with them around their activities that are dangerous, for instance, climbing on a roof, or climate change makes that we have less water in the rivers, so we must be careful, to jump from the bridge, or sport concussions and things like that. And for the teenagers, we developed the superhero module. So it started with an article that you can see here. The idea is that, for instance, Spider-Man has a very healthy lifestyles regarding social cognition and stimulation, education, physical activity, but he has also some negative points in terms of sleep and traumatic brain injury, because he has a lot of traumatic brain injuries and does not wear a helmet. And this is just to finish here with our champion Asterix and Obelix. There was also an article about analyzing the 700 head injuries in these comics books, and this brings fun to the children and the teenagers and help them think about prevention in traumatic brain injury. So again, this was a part of my pilot project and collaborative work, and I want to thank a lot of faculty and GBHI fellow that you can recognize here, and don't hesitate to reach out if you're interested in those empowering approach. Thank you very much.
Thank you very much, Eleonore. That was a very insightful presentation, and we'll come back to some of those issues that you've raised in the panel discussion later. So it's wonderful to welcome our second speaker, Dr. Tatyana Mollayeva. Tatyana is an MD and an affiliate scientist at the KITE Research Institute, Toronto Rehab University Health Network, an assistant professor in the Department of Epidemiology at the Dearbhla School of Public Health, and an associate director of the Acquired Brain Injury Lab at the University of Toronto. Her research interests are in the area of prevention, treatment, and rehabilitation of traumatic brain injury. The title of Tatyana's talk is Understanding Brain Injury as a Process, Not as an Event, Implications for Prevention.
Before I start, I want to thank Gráinne, Mary, and all team members here who joined the talk. And today, as you can see, I will talk about traumatic brain injury as a process, not as an event. And I will look at this from a point of prevention. And thanks to my colleague who already set up stage for talking prevention in traumatic brain injury. I do not have any financial or non-financial conflicts of interest to disclose. As you can see on the screen, research that I will present to you today, in which supports the topic that traumatic brain injury is not an event, but is a process, and we should consider it as a process, is supported by organizations you see on this screen. So this word in traumatic brain injury, a disease process, is not an event, is not my wording. This came from a beautiful colleagues of mine from Galveston, Texas, whom I had the privilege to meet a long time ago, Dr. Maisel, who works with patients. So he put this beautiful paper together, which changed my view on this topic and which allowed my research to explore this topic to some extent, depth, as it was possible for the stage of my PhD in postdoctoral studies. We know that traumatic brain injuries are on a rise globally. This injury is not expected to cease unless we will do something about it. It's expected to double by 2050. And it is estimated that almost every second person will sustain a traumatic brain injury in their lifespan. So we definitely cannot have to make it happen. In Canada, where I am from, and from which country I will present the data that you will see today, we have almost 40 million population. And Ontario, and this is particularly a focus of my research of today, population-based research, constitute almost 40% of Canadian population. So we are talking big numbers and big population-based numbers, which allow us to study traumatic brain injury and potentially develop ideas for prevention. So additional topics that remain to be reasonably unexplored, but which it requires great attention, is sex differences, sex and gender differences. And gender is a social construct, while sex is biological construct, but both are involved in probability to sustain an injury extent, as well as what we have to consider when we develop preventive interventions and initiatives. So beautiful metrics that allow me to study traumatic brain injury as a continuum and not an event is a Haddon matrix. This was known from long time ago. People are using this in research. Haddon matrix has 3 columns and 3 rows, so which basically characterizes a person, an injury, as a person, an environment, and a social an environment and physical agents that reaches a person in injurious amount to cause a traumatic brain injury, and 3 rows. What happens at the pre-event phase, what happens at the event phase and post-event phase, which allow us to some extent think that this can lay a ground for thinking prevention, primary prevention, secondary prevention, tertiary prevention, and quaternary preventions as well. So my colleague already covered prevention. So, but primary prevention, it's basically doing something before an injury occurs, because it's hard to deal with consequences. Secondary prevention recognizes pathology at earliest stage, so we can intervene to reduce morbidity and mortality. And tertiary prevention directed to stop progression of the disease, everything that can be to not let disease progress extremely quickly and minimize disability. So now I will show you research that lay a ground to understand how to formulate primary, secondary, and tertiary preventions in traumatic brain injury. We already know, and this is not something new that I will share, that this is a complex injury. Many factors interact with one another across a human lifespan to complicate the issue of prevention. So, and they interact within each other, not in linear manner. And this is even more harder to formulate preventive intervention at the person of a level, at the level of a person who is definitely at different stages of life, in different socioeconomic standing, in different occupational exposure, environment exposure, and health status at the time of injury. So this complex path of possible association is very difficult to manage in prevention, and specifically in research, when you have a hypothesis-driven research, which stands for linear interaction between variables and focus on certain variables that you have hypothesized to be associated with traumatic brain injury. So how did we deal with this complexity? We decided, so we decided to implement data-driven approaches. So that let data help us to understand traumatic brain injury complexity and how variables interact with one another. So we had an amazing population-based access to population-based data because Canada has a publicly funded healthcare insurance, so which means that people can access hospitals and facilities and services free of charge at the point of care. We look at traumatic brain injury event and look for 5 years preceding traumatic brain injury for each and every person with what was people visited hospital and needed care at the time preceding injury. What you can see on the screen is health status preceding traumatic brain injury in our population. We found 43 health status factors associated with traumatic brain injury and which were present preceding traumatic brain injury. These factors were not evenly distributed between male and female patients, which gives us an indication that we have to think about these differences when we formulate prevention. What you can see on the screen, the larger the font of the number, the bigger association with traumatic brain injury event. And you can see various exposure, including those that relate to environmental hazard, occupational hazard, exposure to toxic gases and fume, work with electrical current, injuries, and the largest on the screen as you appear, and you see potentially that this is clinically relevant, alcohol-related issues, drug poisoning, narcotics, and adult and child abuse. Again, these risks were not evenly distributed between the sexes. We wanted to see how this health status preceding injury are reflected in injury events. So we look whether or not there was any association with external cause of injury. So because we understand that people sustain injury in various causes, including falls, struck by against an object, assault, motor vehicle collisions, and this can be happening in a field or at work. So we did find indeed that health status preceding injury is reflected in injury severity, associates with age, is also reflected in external causes of injury. This additional indication for us that we have to consider external causes of injury and health status preceding injury in order to formulate secondary prevention initiatives. So we look further, so how it is reflected in outcomes that are relevant to people and relevant to us as a clinicians and as a researchers and policymakers potentially to develop truly sensible preventive intervention. So there was excess mortality associated with traumatic brain injury, regardless of injury severity, as compared to life tables, population-based life table. As you can see on the screen, excess mortality rates differed between the sexes, particularly early after the injury in year 1 and more severe injury. Among 43 factors preceding traumatic brain injury, 33 were associated with excess mortality. Irrespective of injury severity and sex, the following had the largest effect. Again, we are dealing with alcohol-related emergency and substance use disorders, liver disorders, which is a systemic disorder, and schizophrenia and delusional disorders. This definitely reflects us to think when we develop preventive intervention. We look at dementia. So dementia is a functional outcome. So people come to the injury without dementia. We excluded those who were like a potential implication of dementia with mild cognitive impairment. We had a look back window, thankfully to longitudinal data we work with. And we did observe that severe traumatic brain injury increased the rate of dementia in both male and female patients, but in male to a greater extent than female, and in younger person in a greater extent than those in older. So as you can see on the screen, what was unclear to us that female patients develop dementia earlier than did male, all other risk and protective factors being equal. So we really didn't know what drives this. Is this that females seek care early and therefore are diagnosed early, and this increased probability to sustain dementia and have it early, or there is something else and there are biological differences or sex differences that might drive these differences. So we had to look at each and every risk factors, clinical risk factors at that point, because we didn't have better knowledge and better data to investigate more environmental hazards in this case. And you can see, in fact, on the screen that the weight that each risk factor pose on male and female patients differ. So we really think that we need to investigate this. As you can see on the screen, effect of tobacco smoking, depression was slightly higher, and in fact, tobacco smoking much higher in female as compared to male patients. Again, to highlight, traumatic brain injury is not an event. We see factor preceding injury reflected in injury event and impacting long-term outcome, including excess mortality, linked to excess mortality and dementia outcome. We see that there are sex differences in both risk and protective, and this definitely needs to be considered when we think prevention. Thank you very much for your attention. All questions are welcome.
Thank you, Tatyana, for that fascinating insight into TBI prevention and your expertise on brain injury, not just as an event, but as a process. I think there's so much to think about in terms of how we should respond. So it's my great pleasure to introduce you to our third speaker here this morning, Dr. Raquel Gutierrez. Raquel is a neurologist based in Madrid, and she specializes in stroke and other cerebrovascular diseases and cognitive decline, especially vascular cognitive decline. In her postdoctoral research, her main research interests are in neuro-rehabilitation and brain repair and plasticity mechanisms. The title of Raquel's talk is Stroke as Brain Injury, Responding to the Multiple Challenges.
Thank you so much for the presentation. I thank my colleague to put the light into the primary and secondary prevention. And now I will put the light in the consequences after strokes, the needs of the patient. What are we doing now, at least in Madrid? But I think that a lot of people will relate with this situation and what we can improve in a very practical way. So stroke is a cause of acquired brain injury produced by a vascular disease in the brain, and it is the second leading cause of disability worldwide. So we have effective treatment for the stroke in the acute phase, but still, even when the better treatment available is administered, almost 40% of patients remain with important disability. And of course, one of the causes of dependency after stroke is cognitive impairment that often is accompanied by language impairment, mood disorders, and also motor symptoms. The prevalence of post-stroke cognitive impairment is highly variable between countries. The main cause of this variability is that we don't have normative tools for measure the cognitive impairment after stroke. But for example, in Ireland, it's estimated to be the 50%, the 30% in Spain, but the numbers are expected to rise for the next decade in the very positive scenario in 125%. This slide relates with the TBI brain damage that Dr. Bayen and Dr. Mollayeva talked before. When we have a damage in a pure primary brain area, we can observe the motor, language, or visual deficit at the time of the stroke onset. So this is the way we diagnose the stroke in a patient. Suddenly we have a motor deficit, that's okay. But the cognitive symptoms like the visual memory, verbal memory are better explained by a disruption in the global function of the brain than the site of the lesion itself in patient with a stroke or with traumatic brain injury or whatever the acquired brain injury is. That means that the cognitive symptoms could not be present during the first weeks or month of the damage onset, but developed in the following months and years, making it harder to diagnose this patient and do the follow-up. So for example, the DSM-5 consider a stroke as a cause of cognitive impairment if the symptoms started in the first 6 months after the stroke onset. But this is made by consensus because nobody knows if a stroke can cause a cognitive decline 1 year after or 2 years later. We don't know because we don't have this information. And the landscape will be even more difficult when other degenerative conditions are present, and it is not a rare situation given the fact that the stroke is more prevalent in older than 65-year-olds, similar to neurodegenerative diseases. So we have a lot of patients with a stroke and also with a neurodegenerative disease. So in Spain, we have a public health system and all the expenses are covered by the government. So when a patient in Madrid has a stroke, the emergency doctors activate the stroke code, which means that the patient is rapidly transferred to a center, to a hospital with stroke units. And once in the hospital, the patient is treated with recanalization therapies if indicated, and always admitted in a stroke unit to give the better treatment and the better care to the patient. Then when the patient doesn't need neurological monitorization or cardiovascular monitorization, is transferred to the regular hospitalization floor. So during the admission, the patient is also evaluated by the rehabilitation doctors and the physical therapy is started. So to that point, this seems a good system, right, for the stroke patients. But what happens when the patient doesn't need an admission in a neurology floor anymore and needs to be transferred to a rehabilitation facility or to an outpatient rehabilitation clinic? Well, we have the option 1, the patient needs hospitalization for rehabilitation and for comorbidities or because of frailty state. So the patient goes to the geriatric floor or a rehabilitation floor with only physical therapy available. And it's very common in Madrid, like for example, logotherapy is not available during the admission and start the logotherapy after the discharge. Option 2, the patient is clinically well enough to go to a comprehensive rehabilitation center just to focus on rehabilitation. That means that not any other comorbidities are allowed to the patient. So the patient is transferred to the CEADAC, which is a center for acquired brain injury with all the therapies available, including cognitive therapy in the public setting. But there is only one center in Madrid for acquired brain injury for a 6 million population community. And the option 3, the patient needs rehabilitation but can be at home, so there are available therapies in the outpatient clinic, which include physical therapy, logopedia, and also occupational therapy. Okay, but the model, of course, had its caveats. For example, as I mentioned before, we only have one center. That means that the inclusion criteria for admission are very rigid. And for example, being older than 65-year-old can be a problem to be admitted, or have another comorbidity also can be a problem. So this is kind of messy because the majority of the patients with stroke are older than 65-year-old. 65, sorry. And for the patient that are not able to reach this center, the situation is not better. For example, cognitive rehabilitation is not available for them in the public setting. For example, the admission in the geriatric or rehabilitation floor usually is restricted to just 1 month to, with this expectation for the family to reorganize the structure, to look for long-term facilities for the patient at home or in a nursery. So it's kind of easy. So luckily, in the private practice, there are some really good rehabilitation centers that work with a multidisciplinary team, as for example, the CIAS Center. This specific center located in Madrid also work with public patients through the service check that the community of Madrid gives to patients with a recognized disability. Here I would like to thank Esperanza Villar, the CIAS director, for the useful information for the conference. But for example, to have this service check, you need to apply for a disability to the government. And this is an administrative process that can take 1 year. So that means that we are losing the opportunity to treat the patient during the first year of a stroke. With luck, 1 year with luck. So the reality is that once the patient leaves the hospital, the communication among the neurologist, the general practitioner, the rehabilitation doctor, neuropsychologist, language therapy is scarce and hard, because the patient has to look for help in different places for different problems, and there are no a proper coordination within professionals further than the personal work that the physicians voluntary or based on their professionality wants to do. So this is really a problem, because as we said before, cognitive symptoms, mood symptoms, post-traumatic stress disorder could not be evidenced at first and detected only with time or when the patient is exposed to the daily life scenario and not evident during the admission. So just for conclusion, stroke is an important cause of acquired brain injury. The cognitive sequels related with stroke are expecting to rise as the population is expected to be older and the increase in the expectancy of life. The post-admission attention of the patient should improve, and the key for improve this post-admission attention is, of course, communication and coordination among the professionals. Thank you so much.
Thank you, Raquel, for highlighting the challenges of brain injury from a stroke and how all our health services will have to rise to the challenge in terms of and how to respond appropriately. So I'm very pleased to introduce you to our final speaker for this part of the programme, Dr. Dearbhla Kelly. Dearbhla is a nephrologist and currently an intensive care medicine fellow in the Mater Hospital in Dublin. Her areas of interest is the overlap between renal and neurological disease. Her research focuses on epidemiology of stroke in patients with chronic kidney disease and potential mechanisms, including the role of hypertension in prevention and treatment strategies. The title of Dearbhla's talk is The Rehabilitation Pathway, Maximizing the Person's Potential.
Good morning, everyone. Thanks so much to Gráinne for the invitation to speak today and to my co-panelists. It's an honor to be included in this illustrious list of panelists. I'm delighted to talk to you about a topic that's very close to my heart. As Gráinne mentioned, I'm currently working in the intensive care unit as a fellow in the Mater in Dublin, and I'm particularly interested in neurocritical care and I guess the needs and deficits of our rehabilitation pathway in Ireland are therefore very close to my heart on a daily basis. And so with this talk, Gráinne asked me to focus maybe particularly on the rehabilitation pathway as it pertains to Ireland, but there are obviously some very generalizable kind of issues and challenges I'm sure that we all face, and I'm going to focus on the individual level, but also on the policy and research level as well. So just briefly going to run through again what is acquired brain injury. I know my colleagues have already discussed this and what its scope is, and I'm going to really focus on what our rehabilitation pathway is in Ireland, and definitely some similarities from the previous talk in this regard. What are the current challenges? What does the research teach us, and what work is needed going forward? So it's, I'm sure many of you are already aware, an acquired brain injury refers to damage to a brain that was not present at birth and is non-progressive. And there are two broad categories, traumatic and non-traumatic, as my colleagues alluded to already this morning in their talks. And stroke makes up a big proportion of non-traumatic brain injury. And there are other causes, of course, like meningitis or hypoxic brain injury, post-cardiac arrest, of course, brain tumors, and then other more rarer disorders. And then traumatic brain injury also covers a myriad of brain injuries as well. And I just wanted to highlight that this group, when we speak about patients with acquired brain injury, it's important to remember this is a very diverse group of people, of different backgrounds, of different ages, who come with maybe lots of prior medical history or no medical history at all, or patients who have other quite significant injuries at the time of traumatic brain injury, or patients who were previously completely well and their world has been, just totally shattered in an instant. So, I think it's important that we bear in mind that rehabilitation, does have to be individualized and kind of take all these factors into account. In the picture on the left here, we can see a gentleman who sustained a traumatic brain injury and some contusions here from a road traffic accident. And in the middle, a patient who's had a stroke, large stroke. On the right, a patient who has some meningitis. In Ireland, so unfortunately, we actually don't have great accurate data on acquired brain injury, particularly with regard to traumatic brain injury, kind of due to maybe poor or suboptimal auditing systems. The national trauma audit has come into, has been in place for a number of years now, but I think given the kind of recent changes in the trauma structure of Irish hospitals, it has been a little patchy, and I think there are possibly, or possibly hasn't kind of covered the heterogeneity or scope of traumatic brain injury in Ireland. But I'm just going to provide some figures here, primarily stolen from Acquired Brain Injury Ireland, but roughly we estimate that nearly 20,000 new brain injuries happen annually in Ireland, and 10,000 of whom are hospitalised, and then about 120,000 people in Ireland are likely living with a disability after an acquired brain injury, and approximately 7,500 strokes happen every day. So this boils down to about 52 people in Ireland who acquire a brain injury every single day. So this represents quite a large group of people who therefore required some focus and special attention. So I probably don't need to tell this audience, but maybe to remind this audience that early access to specialized multidisciplinary neurorehabilitation services is an evidence-based intervention or set of interventions that is associated with better health outcomes for the patient, both patient and non-patient centered outcomes, in addition to its myriad benefits at a societal and economic level. To quote one study, this was a Cochrane review in 2015, 19 studies of 3,000 patients who focused on studies of rehabilitation as an intervention for patients with acquired brain injury, and essentially found that even patients with mild acquired brain injury do benefit from appropriate follow-up and from advice, and then those with more moderate to severe brain injury also benefit from kind of routine follow-up and sort of ongoing needs assessments. And then obviously for those with more severe brain injury, early intervention leads to earlier gains, and more intensive intervention will lead to more gains. And it's likely that interventions can happen quite early within the natural history of acquired brain injury in the hospital. We really need to focus on how we can institute these earlier and in a systematic way. Just to kind of zone out from the individual level to legislation and key health policy in Ireland in the last 20 years, essentially, and it's been a slow burner. I think it's safe to say the Neuro-Rehabilitation Championship in Ireland. Kind of two sort of key documents to highlight here, and is the algorithm from the paper you were involved with, Gráinne, here that was published in Health Policy in 2020, well worth a read. But essentially, the government developed a neuro-rehabilitation strategy in 2011 that really highlighted the need for kind of focus and resources and structure in this area, and unfortunately, it took them another 8 years to kind of come up with an implementation framework for how they were going to actually create this idealistic neurorehabilitation strategy, and the implementation of the implementation framework seems yet to happen. So we're open to some suggestions of that. But essentially, your rehabilitation services, as highlighted in these documents, should be locally delivered where possible, should be individualized to the specific needs of that person, should be early, should be timely, should be integrated and flexible and multidisciplinary. And what this probably amounts to on a practical level is that there are multiple levels of intervention, involving the primary care team, these sort of locally resourced community-based neurorehabilitation teams, specialist regional neurorehabilitation services for higher level of therapy or care required, and obviously national neurorehabilitation services for complex cases. And in these documents, the HSE, Health Service Executives, sort of health governance in Ireland set out this diagram of what they think the ideal rehabilitation pathway should boil down to. So hospital discharge, and then disposition depending on needs, likely multi-disposition here, but essentially should involve specialist neurorehabilitation services, a case manager, access to disability services, integration of primary care, mental health, palliative care services is needed, and other services. And then, ultimately, all of these interventions resulting in a discharge to a home, a supported home environment where the person can lead, achieve maximal sort of functional independence, better quality of life. And the reality, unfortunately, looks a bit more like this, a little bit more meandering and less than ideal. Just to go back to the pathway of rehabilitation, I work in the ICU at the moment, and I think it's incredibly important that we start thinking about rehabilitation, as soon as the patient is medically stable within the ICU, and even sooner. And I think this is a very interesting area because it's not very there's a lot of gaps in the evidence here about kind of what is helpful, when it is helpful, and what is safe. And I think there are unique challenges in patients with brain injury, as highlighted in this really nice review article from 2021, that because of the need to kind of often preserve very robust cerebral hemodynamics, so cerebral blood flow in the kind of acute setting, sometimes this can lead to some early restrictions in terms of movement and sitting out, and sort of de-escalation in terms of taking people off the ventilator, etc. That can maybe delay early kind of rehabilitation strategies. So it's really about trying to find the right balance there, and definitely this is an area that's ripe for more research. But we do know that patients with brain injury do better when they're admitted to a specialist neurocritical care environment, particularly neurocritical care units. So when they're in a unit where there is that expertise and experience, and this is associated with better survival for these patients and better functional outcomes. So I think probably simple interventions related to setting and expertise would be a really helpful start for kind of improving early neurorehabilitation for patients that acquire brain injury in Ireland and internationally. In Ireland, we have a specialist national rehabilitation hospital that does have some specialist neurorehabilitation within it. It has a brain injury inpatient rehabilitation program. It includes 40 beds. There's 120 beds in the hospital in total. It also has an outpatient rehabilitation program, home and community-based rehabilitation program, vocational programs, and then also a stroke inpatient program and associated outpatient rehabilitation programs. So certainly we do have these specialist neurorehabilitation services at a national level, but as you can tell from those numbers there, it is not proportionate to the need for these services on a national level. And this is our single specialist rehabilitation hospital in the country. So obviously can present some challenges from geographical and logistical standpoints as well. Other resources include the wonderful Acquired Brain Injury Ireland, that Gráinne is part of, and we do wonderful work by assisting independent living at home, providing further home and community rehabilitation, clubhouses, family care support, family education, case management, and so a myriad of other great things. And they support over 1,000 brain survivors each year. There's also Crest Brain Injury Services, which is community rehabilitation service located in the west of Ireland, that also provide practical social support, multidisciplinary team involvement. So there are these sort of supplementary organizations and services that have developed in response to kind of the very clear needs of the nation for better neurorehabilitation. So into the end of my talk now, I've spoken about some of the challenges that exist in Ireland, and I'm sure on a more international level, but certainly in Ireland, having better reporting systems for acquired brain injury will help us better service plan. We certainly need more rehabilitation specialists, better political prioritization of rehabilitation strategy and services, to improve the significant waiting lists that currently exist for access to these services, to prevent delayed discharges from acute hospitals and from the National Rehabilitation Hospital. Need to make sure that we're not inappropriately placing young brain injury survivors in nursing homes who would otherwise benefit from more rehabilitation. We need to make sure that it doesn't exist any geographic disparity in access to essential rehabilitation services, and that those at extremes of ages are also not falling into the crack. Some recent and ongoing relevant research in Ireland include this retrospective review of traumatic brain injury in Ireland from 2014 to 2019, published in last year, and essentially showed that we do have quite a high mortality rate from severe TBI in Ireland, and maybe related or unrelated, but certainly not all of our patients necessarily have access or are transferred to kind of specialist neurocritical care or surgical centres. And that is not to say that if they were transferred there, they would do better, but these are proving hypothesis generating studies that we do need to examine more systematically with more research. And then again, there is also this planned, very much needed epidemiological survey of traumatic brain injury in Ireland, the GBHI, Gráinne are involved in, to document our national data, and as well as the pathway of TBI survivors, those providing for them in Ireland. That would be, sure, a fascinating and very important read going forward. I think I've spoken about these. In the interest of time, I'm going to end there, but I'm happy to answer any questions. Thanks very much.
Thank you, Dearbhla, for the presentation on the pathway. I think you've highlighted some of the major policy and service challenges and how health systems need to resource and respond to ensure we have a timely and seamless journey for the patient. So at this point, I'm going to open up, we move to the next part of the webinar, which is a panel discussion on the theme, let's talk about brain health and brain injury, where to next? And this is an opportunity for us to discuss together some of the key themes that emerged during the talks this morning, and potentially how we could explore the next steps and what lies ahead in terms of the work. So with this in mind, I'd like to open it up to the panel. And I suppose let's talk first about prevention, and maybe take a little bit of a further analysis. And maybe I'll come to you first, Eleonore, and then perhaps over to you, Tatyana. From your perspective, what are the key primary and secondary prevention strategies that we need to pursue and prioritise into the future? Eleanor.
Thank you very much for the question. So regarding primary prevention, I think a key point is really, as you mentioned, epidemiological data. At least in France, we lack those data, and we really need them to inform health regulators so that we can articulate a prevention campaign. For instance, we have distinct group taking, for instance, a partner violence. They need to be targeted in a certain way. So it's important to have large data and also tuned data, and also to integrate different campaigns. So for instance, in a road traffic accident, we can see a parallelism between the fact that people are wearing belt and speed. So this was in the 70s, 80s in France, speed limits, for instance, and we can see a real impact of those campaigns on TBI epidemiology. So looking also of the impact of those campaigns can inform health regulators. I think this is of importance. And for secondary prevention strategies, science is really needed. I think we really need our TBI finger studies. For those who don't know the studies in dementia research, it's multi-domain strategies that show a decline, that less decline in those people with dementia when they are coached regarding lifestyles. And we have exactly the same issue here, as I mentioned, and as we saw also in your different talks about, you know, pre-injury factors, post-injury factors, injury factors, all need to be integrated. We need MRI data, imagery, biomarkers, but also lifestyles, the access to specific care pathways that you mentioned. All those data need to be integrated thanks to a complex model, artificial intelligence, to explain in the end brain vulnerability and to try to predict, because this is one of our main issues in TBI, the difficulty to predict worse or better recovery and brain resilience. And this again will also help health regulators, you know, target different groups. So care pathway, for instance, is an issue also when we think about mild TBI. It's very much different than moderate and severe TBI. So we really need to target groups precisely.
Tatyana, and I suppose the same question to you is what do you see as the key primary and secondary prevention strategies that we should pursue and prioritize into the future?
Sorry, I don't. Okay, so let me unmute. I shouldn't unmute. I'm sorry, so just a glitch. So I think I will have to also answer questions that was posed to me in the chat. We are doing quite a lot. We already, I may paraphrase this question. So we already pay attention to smoking and try to eliminate smoking at the population level. What are new factors that you identified which we can focus on to inform prevention? I think personally this question is amazing, and I'm thinking and was thinking about this quite a lot. So what do we do? Traumatic brain injury is very complex. It's definitely a lifelong condition and can appear young age, middle age, old age. So I think that we have to, first of all, think, like Eleonore said, prevention that is precise prevention. So it should be precision public health if we want to put something at the level of a community or population. At the level of a patient, of a person himself, definitely own action mean a lot, but a person is operating within an environment, both social, physical environment, and there can be circumstances which a person cannot control, including people of very young age. So definitely governmental regulation and control of many things and support of communities that are most vulnerable probably are key factors. But to address specific, to be specific, we saw odds of pre-injury factors that were associated with traumatic brain injury. And I'm talking prevention of traumatic brain injury. So understanding that if we prevent comorbidities preceding traumatic brain injury, we may not need to deal with prevention of traumatic brain injury. But now our focus is traumatic brain injury. I want it to be not seen as an individual disorder or disease process. I want it to be seen as a health status transition. So if we miss something early in life, miss comorbidities, miss exposure to environmental hazards, including those occupational exposure, including those that are related to extreme heats and cold, which have been shown to be associated with TBI, including those that are linked to prescribed medications, which have significant interaction effect if multiple medications are prescribed at one, and which are linked to falls and impact postural swing of a person and can be associated in older people with falls. We have to think this. We have to consider this from multiple angles. So definitely taking into account what we saw and how many health status preceding traumatic brain injury are reflected in injury event, we have to probably start from somewhere, from those that are greatest associated or those that impact certain communities and group of people first before going and spread intervention. But we have a lot in our hands, and it should be also support from government, safety protocol, environmental regulation to prevent traumatic brain injury and its adverse consequences. I hope that I answered this question to at least some extent. Thank you so much for your question.
Thanks, Tatyana. Thank you. So what I'm hearing you say is, I suppose we need data, we need precision, we need government responses, but actually what I'm really hearing is that this requires a whole range of players to really make this work. So the interdisciplinary approach is essential to move forward. So thanks very much for that. I'm going to move to the next question. Specifically, I'll address this to you, Raquel and Dearbhla. Maybe starting with you, Raquel. You've already highlighted some of the challenges of the rehabilitation pathway in your presentation, specifically in terms of stroke patients. And I'd like to get your views on what you feel needs to be done in order to address these challenges for the patient with the brain injury.
Thank you. Okay. Well, one of the first thing that we need to do to try to improve these pathways is grab the data. I totally relate with my colleagues here. In Spain, we don't have enough epidemiological data about cognition after a stroke. So if we don't have the data, it is difficult to put the cognition or rehabilitation after a stroke as a highlight to the government to make public policies. For example, we only have one pilot study made in one hospital of 30 patients studying cognition after stroke in 2007. So more than 10 years, almost 15 years later, we don't have data about how the stroke patients are doing in the path of cognition. And the other thing is like this coordination between the systems, because the sensation that I have working I have a 10-year experience working with stroke patients in different hospitals, and the sensation is that I lost the track of my patient because I don't have communication with the doctors in the rehabilitation center or have communication with the GP. The only source of communication that I have with the patient is the patient itself and the family. But I think that this is not the correct path, because we are putting too much on the plate of the families, because they have to adapt the whole structure, they have to adapt to everything, and sometimes they need, not sometimes, always, they need an orientation like this is a good rehabilitation center, or I can talk directly with your nurse or whatever, so he or she can give me professional feedback about your follow-up. So first, grab epidemiological data, of course, and second, try to make an effort in the area of communication to start having regular meetings within the professionals. And this is really hard to do, but I think that this is the only way that we can help the patients.
Thanks, Raquel. Dearbhla, I'd like to hear from you in terms of what you feel should be prioritized in terms of developing the pathway for the patient.
Yeah, I mean, I totally agree with everything that's been said so far. I mean, certainly, I think more data to inform service planning organization would be very, very helpful. I mean, I think that we need to, like, at a governmental level, like, start to kind of implement some of the plans laid out in the previous neurorehabilitation strategy. Framework, and as those plans start to unfold, we need to constantly be conducting research and audit to sort of see and prove that these are, you know, beneficial interventions, and these are, that there's like health economic advantages associated with them as well. I think that we, you know, in the sort of context of trauma reconfiguration and stroke reconfiguration in Ireland, there's an opening for you know, developing acute neurorehabilitation within special services as well, and ideally thinking that more seamlessly with access then to your specialist neurorehabilitation services at local, national level. It's really there kind of both at a patient level, but also at a research level too. I think that there are a lot of interventions there that would be extremely beneficial in terms of, not only clinical outcomes, but also patient-centered outcomes, functional outcomes. My own bias.
So we could have small wins as well as trying to address the big wider policy agenda.
Exactly.
Yeah. Just before we finish, Tatyana or Eleonore, have you anything to say on that particular issue?
I think that's amazing consideration, because you're looking at both what clinicians can do and if they can do, unless government will support them in their action. I think this is an amazing idea that we can do different pieces at the personal level, patient level, at the family level, community. But if government wouldn't support clinician and a patient and their family in achieving this goal, then it would be probably very difficult and cannot be thought as continuity. It would be very fragmented actions, which potentially wouldn't lead to a great impact at the level of the country or community. So regardless where we are. So I think we really need government and policy to support our actions, because knowledge is there, data is there. We just need to have means to do something with this knowledge.
I think we really need to talk about the sort of geographic equity as well. Because this exists not only rehabilitation, but for lots of other essential services as well. It's crazy 2023 that your address, so something as arbitrary as your address will affect your access to services.
Very inequitable situation, and that's across the world. So I think what's happening in each of our countries is reflective of what's happening across the world. So I think your point around, clinician leadership from clinicians, but we also need political leadership. We need policy leadership. We need people to go out to advocate for this issue, to try and bring about some change and some investment in the pathway.
And I think, sorry, to add that I think this is what we do, right? It's a Global Brain Health Institute, and this is what leaders of the Global Brain Health Institute envisioned when they all brought us together from different disciplines, different field of study, different work position and countries to work together, so to have developed this idea to something very meaningful and to change inequity in brain health.
Maybe just to add on that, I think in France, but also in other countries, TBI is often referred as a silent epidemic, and it is also referred as an invisible pathology. For instance, in France, even if it's as frequent as stroke, it is not in the training of medical students. I know it's crazy. It's usually also the fact that people are not always in a wheelchair after a TBI, but they have invisible handicap in terms of cognition. We discussed that. We have a lot of loss to follow-up patients, and because general practitioners don't learn about TBI, so these care pathway issues are very important, and I think it's really a worldwide issue that has a lot to do also with information. And this also goes with the litigation procedure, which again is very specific in traumatic brain injury, but which can make a difference in people's life when they got a financial compensation. And lots of patients never get to that point, or have very sparse information and just get a little bit of money or no money at all from the third responsible party. And this, of course, has a huge impact when you have lost your job, when you are a father from a family. And so I think from this perspective, it's really
pathology that needs to be addressed more in every field of the medicine and also in society.
Thank you very much, Eleanor. It's time to draw the session to a close. Can I say a huge thank you to you for attending and for being part of this event. An enormous thank you to our 4 speakers, Tatyana, Raquel, Dearbhla, and Eleonore. And a huge thank you to Mary Warbello here in GBHI for all her technical support, and to Helen Murray in communications here in GBHI as well for all her support. I think this has been a wonderful opportunity to talk about brain health and brain injury. And I'm keen to link with others who are interested in this area. So if you want to chat more, please get in touch. There is a lot more work to be done. Can I wish our speakers and any of those of you who are online and attending it all the best with the World Congress on Brain Injury. And I'll see you there.